This video is on the spinal cord. Everything we've talked about so far in the nervous system has been kind of confined to this region. We talked about the brain stem, the cerebellum and stuff. But there's so much more to the nervous system than just this region. I mean, think about the nerves all the way to the tips of your fingers and the tips of your toes. Those nerves need to send impulse to your brain, right? And your brain needs to send impulse back. How does it do that? It does that through the spinal cord. Your spinal cord is this long tube of tracts of nerves that kind of gather all the information from your peripheries, send it to your brain. And your brain will process it, send it back. So if I just give an example, let's say I accidentally touch the stove. Yeah, and it's hot. Well, I need to send sensory information to my brain, and it does that through the spinal cord, and my brain will process it and then send motor information back, again, through the spinal cord, and it'll tell my hand to move, get away from that hot stove. Now let's just talk about the anatomy of the spinal cord. If you get a cross section of the spinal cord, now the tracts, the nerves that send and receive impulse are very highly myelinated, highly bundled, and so they appear white when you do a biopsy of the spinal cord. They appear white, and they're usually on the peripheries. So we have those tracts on the peripheries that we're going to talk about today. But that's not the only thing that exists on your spinal cord. You can have just regular neurons and regular synapses. And those aren't as myelinated, aren't as tightly bundled, and so they look kind of gray. We call that gray matter. And gray matter kind of looks like this. I'm blocking your view, but I'm trying to make this as symmetrical as I can. All right, so the gray matter looks kind of like this. There's a little central canal. We can split the spinal cord kind of in half. All right, and if this is your left half, then this will deal with all the left side stuff, and this is your right half, this will deal with all the right side stuff. And this end is your posterior end, sometimes called the dorsal end. So this will basically be the back part where your spinous process is. And then that means this end is the anterior, sometimes called the ventral end. This is what your spinal cord looks like grossly. Now that kind of depends on what level your spinal cord is. Your cervical spine looks a little bit different than your lumbar spine. And sometimes they expect you to know differences. I'll put a nice picture in my notes that kind of illustrates the differences. But grossly, this is how it looks like. Okay, so your gray matter and your white matter. Now the white matter is what we're going to be talking about. Your spine has generally two functions. It takes stimuli, from your peripheries, sends that up to your brain. It goes up to your brain. It ascends. We call those ascending tracts. Then once your brain and your thalamus has processed it, it'll send signals back down, tell it what to do. We call those descending tracts. So your ascending tracts will take all the stimuli, the sensation that you feel, and send it up. So ascending equals sensation. And then once your thalamus and your brain has processed it, it will send signals back down, usually in the form of motor. So descending tracts, usually in the form of motor function. Tells you, hey, that stove is hot, move your hand. So we have your ascending tracts and your descending tracts. Let's talk about ascending first. This is all sensation. Ascending, you have some columns of ascending fibers in your dorsal region. We call these dorsal columns. I'll just write dorsal columns. And your dorsal columns deal with sensation like pressure, like vibration, touch, proprioception, and you can break it up into the fasciculus gracilis and the fasciculus cuneatus. The fasciculus gracialis deals with your sensation of your lower leg, lower body, and legs. The cuneatus deals with your upper limb. It's not too hard to remember. The most medial, the most midline deals with your midline structure. So your lower limb, your legs, and then your more laterals. And then your more lateral dorsal column deals with your more lateral structures, your upper limb, your arms. And then I always remember gracialis sounds like graceful, and I think of ballerinas as being graceful, and they use a lot of lower legs, so that way I can remember lower body, legs is gracialis, and the other one's the other one. Okay, so those are your dorsal columns. And there's another ascending tract that sends sensation to your thalamus, to your brain, and it's located in the anterior part of your spinal cord. And this anterior tract that sends sensation from your spine to your thalamus is called the anterior spinothalamic tract. Anterior spinothalamic tract. Anterior spinothalamic tract. And this also has to do with things like touch and pressure. Touch, pressure. Now you're saying that deals with a lot of sensation, but there's some sensation that we're missing. Some really important sensations. How about things like pain? How about things like temperature? Lucky for us, we have some ascending tracts that deal with sensation right on the lateral side of your spinal cord. And these lateral tracts send information from your spine to your thalamus. We call it your lateral spinothalamic tract. Lateral spinothalamic tract. And these are the ones that deal with pain and temp. Those are your ascending tracts. That's easy enough. Your descending tracts have to do with motor. I'll draw an orange. So you have two descending tracts. You have one located near your anterior end. You have one located on your lateral end that send motor signals from your cortex, your motor cortex, down to your spine. What do you think we're going to call this? What do you think we're going to call this anterior tract that sends signals from your cortex to your spine? We'll call it your anterior corticospinal tract. Anterior corticospinal tract. How about the lateral? We'll call it your lateral corticospinal tract. And these are all motor. And there you have it. Now that's one side of your spinal cord. What's on the other side? It's the same thing, it's just mirrored. Okay, so this deals with one side of your body, this deals with the other side. So that is the anatomy of your spinal cord. Hopefully that wasn't too bad. Now let's talk about what can go wrong, some pathology. You can have occlusion of your anterior spinal artery, or anterior spinal artery. And judging by the name, it's going to be an artery that goes from your anterior side. And this artery will kind of fan out and cover everything but your dorsal columns. Spares dorsal columns. The occlusion over here is common because it's a watershed zone. It's shared with another artery called the artery of Adam-Kiewitz. All right, so it can occlude and you have loss of everything but your dorsal column. So what do you think you're gonna have? What signs are you gonna show? Well, it affects your motor tracts, so you're gonna have motor weakness. It affects your tracts that deal with pain and temp, so you're gonna lose pain and temp. You're gonna have your dorsal column spared, however. So you're gonna have intact things like pressure, vibration, proprioception. I'm gonna write intact, vibration, pressure, proprioception. So if you have it illustrated all out and labeled all out, then these should be easy. I'll give you another example. This is the exact opposite of occlusion of your anterior spinal artery. This is tabes dorsalis. Whereas the first one spared your dorsal column, this deals with your dorsal column. Why do you think we call it dorsalis? It mainly attacks your dorsal columns. So it attacks your dorsal columns. What attacks your dorsal columns? This is tertiary syphilis. Tertiary syphilis can disseminate and attack everything, basically. It can disseminate to your skin, to your brain, to your heart, anything. So it can disseminate to your spinal cord and attack your dorsal columns. So all right, tertiary syphilis. What deficits do you think you'll show if it attacks your dorsal columns? It's right up there. So You don't even have to look at your notes. You can just look right up there. Loss of pressure, vibration, touch, proprioception. They'll have Romberg sign where you ask them to close their eyes and they're stumbling all over the place because they don't have any proprioception. All right, Romberg positive, Romberg positive. So loss of proprioception, vibration, all that stuff. All right, that's just kind of a given. It can attack a lot of different places. I'm just going to generally talk about it. Outside of the spinal cord, it can attack, you can lose reflexes. You can have Argyll-Robertson pupils as well, which is a classic finding in syphilis. The proposed mechanisms I really know, but I'll just write it down. Argyll-Robertson pupil. We'll say a patient comes in, we'll say a patient stumbles in, has decreased mental status. You look in the eyes don't react to light, but they do accommodate Argyll-Robertson pupil. Syphilis serology was positive, and then they might ask what part of the spinal cord is affected. Affects your dorsal column, tabes dorsalis. Let's give another example. Friedreich ataxia. We already talked about Friedreich's. So you know what I'm going to ask you. I'm going to ask you everything you know about Friedreich ataxia. Friedreich ataxia, that was the trinucleotide repeat, GAA. That was a mutation in frataxin, which regulated mitochondrial iron. So you can't regulate that. You have iron, free radicals, destroys your mitochondria, destroys your spinal cord in multiple tracts. So it's very non-specific. However, something that gives away is they also have skeletal deformities, things like kyphoscoliosis. And we said that, of course, it's not only affecting your spine. That wouldn't make sense. It affects everywhere else. It can affect your internal organs. It can affect your pancreas, cause diabetes. And it can affect your heart, cause cardiomyopathy, and that's how they die. All right, so we reviewed Friedreich's. Don't forget it. Hopefully you were able to recall all those facts. I'll just write some of them, the most important ones. GAA, nucleotide repeat, frataxin. We said they had kyphoscoliosis, DM, diabetes mellitus, and then cardiomyopathy, CM. I'll give you another example. B12 deficiency. B12 deficiency attacks your dorsal tracts, dorsal, and your lateral corticospinal. Lateral corticospinal. What deficits do you think you'll see? You can just look at the picture. You're gonna have affecting your lateral corticospinal, so you're gonna have motor weakness. You're gonna have it affecting your dorsal column, so pressure, vibration, proprioception, loss of all that. And don't you see that in people with B12 deficiency? Exactly, now you know why. A lot of questions I've seen on it. On B12 deficiency, they'll show pictures of the spine and the different tracts. Let me draw out the spine again. And some pictures will show the dorsal tract affected. Some pictures will show only the anterior corticospinal tracts affected. Some pictures will show dorsal and anterior affected. The one you're looking for would be your dorsals affected and your lateral corticospinals affected. Okay, so it's kind of like a picture show, like a match, mix and match. Match the one that's dealing with B12, that's dealing with dorsal and lateral corticospinal. So if you can identify that, great. So I just write motor weakness and impaired sensation, proprioception, etc., etc. Last but not least, syringomyelia. Syringomyelia. Syringomyelia is a cyst. That's this long tubular cyst that looks kind of like a syringe. That's why I call it syringomyelia. And it can blow out your lateral spinothalamic tract. What deficits do you think you'll see if you blow out your lateral spinothalamic tract? It deals with pain and temp, doesn't it? So you'll lose the sensation of pain and temp. Usually they call it, it spreads around your neck, your shoulders, and your arm. They call it cape-like, or whatever that means. But it usually spreads around your arms. They think it's a malformation or something, and this malformation is associated with other malformations. It's associated with things like kyphoscoliosis. What did we just talk about also has kyphoscoliosis? Friedrichs. It's also associated with Chiari. Tell me everything you know about Chiari. Chiari is herniation of your cerebellum through your foramen magnum. Absolutely right. Good. Some questions I've gone on syringomyelia. We'll talk about a patient who comes in and has burns all over their arms, and they didn't even notice they have burns all over their arms. How did they not notice they burnt their arms? Because they don't have pain or temp sensation. So they'll be cooking, and then all of a sudden they'll kind of graze a hot stove and not even realize. And then a couple days later they'll look down, there's blisters. Oh, I just burned myself. So they come in with burns all over their arms, syringomyelia, and then they might ask things like, what else could you possibly find on MRI? You might see cerebellum herniation because they might have Chiari, etc., etc. Or they might ask what tract is destroyed, lateral spinothalamic tract. Okay, easy enough. So if you're imagining this syringomyelia, you might think, okay, that expanding cyst, it affects the lateral spinothalamic tract. So it must be kind of right here. And you'd be wrong. It instead likes to affect the central canal, and these white fibers in your anterior end of your spinal cord called the anterior white commissure. So it likes to affect the central area. Why on earth then would it be able to affect your lateral spinothalamic tract? That's odd. That leads me to my next topic of the spinal cord. You see, in an ideal world, you'd have your nerves go straight up to where it needs to go and then straight back down. Yeah, straight up, straight back down. Nice and simple, right? So I just write, in an ideal world, our nerves will be nice and straight. Also, in an ideal world, it'll just be one nerve, one single nerve that goes straight up where it needs to go, straight back down. Yeah, nice and simple. So one single nerve. But the world is not ideal. The world is complicated. So instead of having a straight nerve that goes straight up to where it needs to go and straight back down, it likes to zigzag. We call that decussate. That's a fancy word for crossover. So you don't have a nice straight nerve. We have decussating nerves. And instead of one neuron that goes straight to where it needs to be and straight back where it needs to be, we have several neurons that talk to each other, kind of like middlemen. We call these neurons interneurons, neurons between neurons. So instead of one nerve, we have interneurons. And that just confuses things a little bit further. So your nerves cross over, and there's also a bunch of them that make up these tracts. Let's talk about the crossing over part first. And we'll start with the ascending fibers. So your dorsal columns, your spinothalamic tracts. We'll start with your dorsal columns. All right, dorsal. Let's say there's your spinal cord. And we'll say it's like C5. And then above it you'll have C4, and it keeps going C3, C2, all the way until you hit your brain stem and your brain and your thalamus. Okay, so your dorsal nerve roots will enter in your dorsal area, and it will ascend up. So go from C5 to C4 all the way up till it hits your brain stem, where it hits your medulla. And when it hits your medulla, it will cross over. It will decussate. And so if it was originally on the right side, now it's on the left side. So it's contralateral. And it will keep going until it hits your main relay center. What's your main relay center? Your thalamus. What part of your thalamus? What part of your thalamus deals with all your sensation from your spinal cord? That'd be your VPL. Yeah, so it hits your thalamus, your VPL, and then your thalamus will send it to your sensory cortex. That's your dorsal columns. Now let's talk about your spinothalamic columns. Spinothalamic. Your spinothalamic columns, if we draw it out again, this is C5. C4. And it keeps going up until you hit your brain stem and your brain and your thalamus. And your lateral spinothalamic tract is here. So nerve roots will enter your lateral spinothalamic tract and immediately cross over, immediately decussate. Cross over. Now it's on the other side. Now it's on the contralateral side. And now that's on the opposite side, now it will start to rise and ascend up the brain until it hits your until it hits your main relay center, which is your thalamus. What part of the thalamus? VPL, where it gets processed and sent where it needs to go. Okay, so very distinct differences. What got us talking about all this in the first place is we were talking about syringomyelia. We said syringomyelia blows out the middle part of your spinal cord. Yeah? If you blow out the middle of your spinal cord, will that affect your dorsal columns? No. Dorsal columns comes in dorsally and it stays dorsally, stays far away from the middle, all the way up to your medulla, and then it goes to your thalamus and lives happily ever after. Does it affect your spinothalamic tract, your lateral spinothalamic tract? Let's see. If it blows out the middle, then your lateral spinothalamic tract will come in, immediately cross over, and get caught in that cyst. Yeah? So it does affect your lateral spinothalamic tract. That's why it is affected in syringomyelia. Understand. Now, just as a disclaimer, if your syringomyelia is big enough and it blows out your entire spinal cord, then it'll wipe everything out. But for the most part, know that syringomyelia is associated with lateral spinothalamic tract. So that was our talk on crossing over decussation. Now let's talk about the fact that there's not just one singular neuron, it's multiple neurons, interneurons. Again, we'll start with your ascending tract, your dorsal tract. Like I said, your dorsal root will enter your dorsal tract. This is your first neuron. Sometimes we call it your first neuron or your first order neuron. So, right, first order. And it will immediately synapse with another neuron. So synapse with another neuron. And this is the neuron that goes all the way up, decussates in the medulla and hits your thalamus. This is your second order neuron. And this will eventually synapse and meet your last third order neuron, and that goes to your sensory cortex. So third order. Not too difficult there. How about your spinothalamic tract? Well, it does pretty much the same thing. So it'll come in on the lateral end. This is your first order. It will synapse and meet another neuron. And that neuron will immediately cross over, immediately decussate and go all the way up to your thalamus. And once it hits your thalamus, it will meet this third neuron, kind of like here, third order. And that is how it does things. That's not too bad. They look kind of the same. The only difference is where they cross over. That is your ascending tract. Now, I talked a lot about ascending tract. Why am I skipping over your descending tract? Why am I skipping over your motor tract? Let's talk about that now. We said your motor tract deals with sending motor signals from your motor cortex, your cortex to your spine, corticalspinal tract. So if we look at it from this back angle, your hemisphere, that doesn't look like brain hemisphere, but just take my word for it. And this is your brain stem, this is your spinal cord. And it makes your, again, this is your C4, C5. It will get the signal from your motor cortex. And that signal will descend down your internal capsule where it hits your medulla. And from your medulla, it will cross over. So right, decussate, medulla. Now that it's on the contralateral end, contralateral, it will go down to whatever tracts it needs to go down, whatever corticalspinal tract it needs to go to. So this would be your first order. It will meet another neuron that will leave and actually innervate your muscle. So this will be your second order neuron. That is how it both decussates and how it changes neurons. The most important thing you need to know is that it doesn't use the term first order neuron, second order neuron. It likes to be fancy. Instead of using first order neuron and second order neuron, the first order neuron is going to be called the upper motor neuron. And then the neuron that actually leaves and innervates the muscle is your lower motor neuron. The lower motor neuron is the neuron that actually leaves and innervates the muscle. That is your lower motor neuron. And everything above it is the upper motor neuron. Everything above it is the upper motor neuron. It's very important you understand that. Why is it important? Let's say this tract keeps going down to the level below it, and that leaves and innervates the muscle. Now if we're looking at this level, then this becomes a lower motor neuron. And like I said, everything above it is the upper motor neuron. So that would mean this whole system is now upper motor neuron. That includes the nerve we were just talking about. Yeah, so everything now is the upper motor neuron. Why is it so important to make that distinction? Well, your lower motor neuron innervates your muscle. That's the actual nerve that innervates your muscle. So if you knock that out, then lower motor neuron signs will show up as the inability to innervate that muscle. So if there's a problem with your lower motor neuron, it can't innervate the muscle. Can't innervate muscle. And it will show up as signs. And it'll show up as signs that demonstrate that. So you have decreased tone, decreased reflex, decreased power, because you can't innervate the muscle. The only exception to this whole decreased thing is you get fasciculations, or basically looks like twitching. And the proposed mechanism is that it's so starved of innervation that it will automatically depolarize and cause fasciculations. So those are all lower motor neuron signs. Signs that something's wrong with your lower motor neuron, the actual nerve that innervates your muscle. How about if there's something wrong with your upper motor neuron? Signs of damage anywhere above that. Well, your upper motor neuron, the purpose of your upper motor neuron is it always sends inhibitory signals. That way, when we're resting, we're not moving. We have inhibition. Otherwise, if it didn't send those, then we'd have movement all the time. That'd be terrible. So your upper motor neuron sends inhibitory signals. And if you have a lesion there, then you lose that inhibition. And you have signs of that. You'll have increased tone. You'll have increased reflex. You'll have spasticity. So in upper motor neuron lesions, everything is increased. Most students don't have a problem with remembering these signs. As long as you remember fasciculations and lower motor neurons, that's the only tricky one, I guess you could say. Let's talk about some diseases that affect your upper motor and your lower motor neurons. See if you can really understand what's going on. We have werdnig-hoffman disease. Werdnig-hoffman disease is an inherited disease that affects your lower motor neurons. All your lower motor neurons. So what do you think will show up? You'll have all this: decreased tone, decreased reflex, decreased power, and the child will look floppy. Floppy baby. Floppy baby. From birth. Another thing that can affect your upper motor and lower motor neurons, polio. Polio likes to affect your lower motor neurons. So what do you think you'll see? You'll see all this. Now how can you tell this apart from Werdnig-Hoffman? Well, polio is a virus. All right, so the history will be much different. And also, whereas Werdnig-Hoffman is an inherited disorder of all your lower motor neuron, polio is asymmetric. It affects some parts of your spine, spares some parts, so it's asymmetric. All right, so some patients might have it in their arms, or have it in their legs, and so asymmetric. History of infection. Both of these are lower motor neurons. All right, so it's a good microbiome tie-in. So tell me everything you know about polio, and then synthesize it into a step-by question. So pause the video and do that. And after you've done that, let's move on. Last but not least, ALS. ALS destroys both upper and lower motor neuron. So upper motor neuron, like your corticalspinal tract. Lower motor neuron, like the actual nerve that innervates your muscle, your ventral horn. So lower motor neuron. And is purely motor. I've seen a lot of questions on ALS, and they'll ask, is there a problem with their mental function, their memory, their sensation, their Their feelings of vibration, touch, proprioception. No, it's a purely motor problem. What do you think you'll see if you affect both your upper motor neuron and your lower motor neuron? You're going to have those differing symptoms. You might have an arm that has no tone, no reflexes. Those are all lower motor neuron signs. And then you might have a leg that has upper motor neuron signs, so it has increased tone. You hit the knee reflex and it like kicks you off the floor. You have spasticity, so you have a combination of the two, and they'll be in the history. They'll have a history like this long and talk about where some body parts have lower motor neuron signs, some body parts have upper motor neuron signs. ALS. What causes ALS? No one really knows. There are some proposed mechanisms and some genetic mechanisms. 90% of it's sporadic, but there are some causes that we know, and we really like to gravitate towards those because those are the only ones we kind of know. One of those is SOD1 mutation. SOD1 is superoxide dismutase, and that kind of controls your free radicals. And if you have a mutation in that, then you can't control those free radicals, and it can damage your spinal cord and cause ALS. So SOD1 mutation is one you definitely need to know. Now, treatment-wise, ALS is incurable. It's progressive. Usually, one of the things you worry about, or one of the common ways they die, is they lose the motor function of their diaphragm. They can no longer breathe. They die, so you have to give respiratory support. There is a drug that prolongs a beat very slightly their lifespan, and that is Relaxol. And Relaxol decreases glutamate. That's your excitatory neurotransmitter. Why that helps in ALS, no one knows. I don't know. But you need to know Relaxol. So that's a lot of information. Pause the video, take all these variables and synthesize it into a step-like question. We're going to talk about one more thing that affects the spinal cord. Very rare, but they like to talk about it because it culminates everything we talked about thus far. It culminates your understanding of the anatomy of the spinal cord, and it also talks about, and also deals with the decussation and the inner neuron. So it culminates everything, and that's why they like to ask us so much. Does it happen a lot? No, but they want you to know it very well. That is Brown-Sicard syndrome. Brown-Sicard syndrome. Brown-Sicard syndrome is when you blow out half of your spinal cord. So this is all gone. This is all gone. And so we'll draw our trusty spinal cord. We'll say this is so asymmetric. We'll say C4. This is C5. C5. This is C6. And we'll say C5 is where you blow out half your spinal cord. What are the symptoms that you will show? We'll just break it into ascending and descending. So ascending, at the level of the spinal cord, what kind of sensations do you think you'll feel? You'll feel nothing. At the level of the spinal cord, you're not going to feel sensation because you don't have a spinal cord essentially. So whatever this side is, your left side, you will have complete left side loss of sensation. So loss of sensation. Below the spinal cord, what do you think you'll feel? This is a little bit more tricky. So let's just recap our ascending tracts. We had our dorsal column and your anterior spinothalamic and your lateral spinothalamic. Anterior and lateral. And lateral was the main one we talked about. So what's the process? So tell me again. So we'll just say this is your left side of the spinal cord, this is your right side. How do these tracts go to your brain? The dorsal column will stay on the same side, ascend, all the way up till it gets to your medulla, and it'll cross over, right, and goes to your thalamus sensory tract. Your lateral spinothalamic, on the other hand, immediately crosses over. Then it'll ascend, get to your thalamus, go to your sensory cortex. Why is this important? Well, your left-sided dorsal column will ascend immediately hit that broken spinal cord and you basically hit an impasse, won't go any further. So below the lesion, you'll have ipsilateral dorsal column loss. So loss of pressure, vibration, touch, proprioception, etc., etc. How about your spinothalamic tract? Well, this is the left side, then it'll go to the right. Go. Right through. No problem at all. So ipsilaterally, so your ipsilateral tract has no problem at all because it crosses over and leaves. How about your contralateral side? How about your right side? Well, that will cross over, ascend and hit that broken spinal cord. So you get contralateral spinothalamic loss. So you get contralateral loss of pain and temperature. Comprende? That's your ascending tracts. How about your descending? How about your motor? We said your motor comes from your cortex and that descends your brain, crosses over your medulla, and goes and supplies your spinal cord. And there are nerves that come out of your spinal cord that actually supply your muscle. So it keeps going. Nerve that comes out that supplies your muscle, keeps going. Nerve that comes out supplies your muscle. So at the level of the lesion, and you blow out your entire spinal cord, it'll blow out this nerve that supplies the muscle. Is that nerve upper motor or lower motor? It is lower motor, the nerve that supplies your muscle. So at the level of the lesion, you have lower motor signs. How about below the lesion? Anything wrong with this nerve? No. Lower motor is fine. Anything wrong with things above it? Yeah, you don't have a spinal cord. So this is all upper motor. So below the lesion, you have upper motor neuron signs. And that is Brown-Sicard syndrome, and you gotta know well. All right. If you draw it all out, it's not too bad. Hope this clears up spinal cord anatomy. Hope you enjoyed the video. Thanks.